Good morning, guys. It's Miss Bud. I am going to go over some EKG stuff today. We're closing in on test time, so the next practice test will be tomorrow. We don't have the computer labs, so we'll have to do them on laptops in the actual classroom. So next practice test tomorrow, and then we also are having some delay. We're working on getting the codes we need to get you guys registered. For your tests. So hopefully I'll have those later today or first thing tomorrow. We'll get you registered on the NHA site for your tests. So turn to page 227. I want to talk real quick about EKG. I do want to remind you guys from yesterday on phlebotomy. One thing I did not say, and I think maybe Miss Taylor talked about it. It's in the book, but I talked about the angle that you hold your needle, page 220. When you go to insert the needle, when you're drawing blood, of course, it's always bevel up, which bevel is the slanted part of the needle. You always want to hold that and go in at about a 15 to 30 degree angle. If you go in at a higher angle than that, then you're going to come down on the vein and go straight through it. If you go too shallow, where you don't have enough angle at all, then you can run across the top of the vein and not be in the vein. Okay, so just a reminder that it's 15 to 30 degrees. The only time you can go a little less is you can do 10 degrees in the hand. Okay, but normally you're going to hold that needle and insert at a 15 to 30 degree angle. All right, page 227. So I'm going to go through EKG here. There's really not a lot to touch on, but I want to touch on a few things. Same thing as always. Before you start with an EKG, you're going to confirm what the order says. You're going to also identify the patient. Make sure you've got the right patient. One of the biggest things with EKG is you want to explain to the patient that it is pain-free. That a lot of patients think that there's going to be some sort of shocking involved or that there's some sort of discomfort. An EKG is painless, okay? The worst that can happen is they may get some sticky stuff on their chest from the leads and electrode pads. So it's completely pain-free. But a lot of patients come in with this idea that if they have an EKG, is that going to shock them? Is it going to hurt? So that's one of the things you always want to go over with them. Basically, they need to take off all their jewelry. So like if I was going to have an EKG, this necklace would need to be off, okay? And they need to be undressed from the waist up. And you need a good cover. Sorry guys, you need like a drape that you can put over them on the top while you're putting the stickers on. So, okay, so with EKG, what you want to think about is an EKG, a normal EKG that when we were just referred to EKG, we're usually talking about a 12 lead EKG. But a 12 lead EKG, in a 12 lead, we only place 10 leads, okay? So what that means is even though we place 10 leads, it reads from 12 different areas. So the term 12 lead EKG can be confusing when you go, well, wait a minute, I'm only putting 10 leads on this patient, okay? But that's normal. So that is why it's called a 12 lead EKG. It's reading from 12 different planes, okay? All right, a couple things about when you look at the EKG paper. And when it's coming across the paper horizontally, okay, that's what we would think of as the horizontal axis, or if you're thinking math, it's the x-axis, okay? But as I'm coming across the paper this way, that represents time, all right? As I'm going up the paper vertically, that represents amplitude or gain. And the best way I can explain that, guys, is if you look on page 233. If you look at this beat that it shows here on page 233, as it moves this way, it's showing you how long it lasts. As it moves up, you're looking at, when we call it amplitude or gain, I always like to think of it as power, okay? So for instance, you'll notice that the P wave there on 233 doesn't register as high as the QRS complex, because the P wave, which is when the atria contract, is not as strong as when the ventricles contract. So if you are looking at this printout, what you are seeing is a reflection of strength shown in how high it traces on the EKG paper, okay, if that makes sense. So think about it. The atria are smaller, the ventricles are larger. So when the atria contract, that's not gonna contract with as much power and force as the ventricles, because the ventricles are bigger, okay? So it's like if you hooked up a little bitty car and revved the engine, and we traced out what that looked like, versus a really big, F-150 truck, and gunned the engine and traced out what that looked like, okay? We would expect that truck to trace way higher in amplitude or gain to show more power than we would the smaller little Versa or something, okay? So amplitude or gain simply has to do with the vertical height of the tracing. And when it's going this way, it has to do with the time of the tracing, okay? All right. I want to talk a little bit about lead placement. If you look on page 231, on page 231, what you're seeing there are what we call the precordial leads. So first you have 4 limb leads, okay? You have a limb lead at the right arm, left arm, right leg, and left leg, and they've got them listed out here for you in color. It's white is the right arm, black is the left arm, red is the left leg, green is the right leg. Okay, so that's your 4 limb leads. You place those. Then you have your precordial leads, and these are the ones you really need to remember for the test, because you will likely have a question that tells you, ask you where you might place a lead, okay? And so what I always tell my students, I'll actually come down and show y'all this at the end of class today, but I'll show you actually how to place these leads and how to remember it. But it's the V1 through V6, so I would encourage you to just commit to memory V1 through V6. Again, I'll come down during class today and show y'all. Okay, the actual waveforms, this is what you need to know. You need to know that a P wave represents atrial depolarization or contraction. So a P wave is showing you when the atria contract. All right, a QRS complex is ventricular depolarization, or when the ventricles contract, okay? A T wave is when the ventricles relax, and a U wave will sometimes be there, and that is usually, it represents repolarization of the bundle of His, and you usually see that when a patient has electrolyte imbalance. So if their potassium is low, then you will maybe see a U wave, okay? Those are the ones you really need to remember, P, QRS, T, and U. So commit those to memory for sure. And then it gets on into your artifacts and your strips. So I know you all made cards. You basically, again, just need to commit these to memory. Somatic tremor, AC interference, wandering baseline, and interrupted baseline they don't give you a picture of. But somatic tremor is caused by the patient shaking. So if they're having a seizure, or if they have Parkinson's or something that makes them shake all the time, you could see somatic tremor. One of the things you can do for somatic tremor is have them place their hands flat beside them and put them under their low back or buttocks, okay? AC interference, turn off all electronics. It just means that something's interfering with the tracing. So turn off cell phones, TVs, radios, anything that's on. And then a wandering baseline is usually from a patient maybe having like too much oil or powder or something on their skin, and it causes it not to get a good tracing, okay? And then your rhythms, you just need to remember the rhythms, guys. And you need to know that the ventricular rhythm, so on page 237 where you see ventricular fibrillation, that needs immediate intervention. If you look at that on ventricular fibrillation, there is really no coordinated contraction at all. Basically, the heart works on coordinated contraction, atria ventricles, atria ventricles, atria ventricles. If you look at ventricular fibrillation, the ventricles are just quivering. That person's gonna die quickly if something is not, if there's not some intervention. So 237, you're calling for help, you're getting an AED, you're starting CPR, okay? And atrial flutter and atrial fibrillation are also really serious, because again, there's not a lot of coordinated contraction. And what happens is you might have the ventricles are contracting, but the atria are just kind of shaking and fluttering, and that means that a patient can easily get a blood clot. Okay, so those need quick intervention too. Okay, the other thing I wanted to talk about a little bit was stress testing and Holter monitoring. So stress testing is where a patient goes in and they put the patient under stress and see how the heart responds. We always joked and would say, okay, if the stress test didn't kill you, then your heart's fine. Because what they do is they take a patient, they bring them into an outpatient setting or hospital setting, and they will put them on a treadmill. And they will run them hard on a treadmill. And they will monitor how their heart responds that entire time that they're on the treadmill. If they can't run, they might put them on a bicycle. There's also a way they can do it by stressing the heart with medication. If the patient's older and can't run or get on the bike and really go fast enough, you can stress the heart with medication and watch how it responds. But that is what a stress test means. A stress test is where we either physically or chemically with medicine put the heart under stress and monitor what happens to it then. Because you can tell a lot about what's going on with the patient when you monitor them while they're active. Okay, and then the other one is called a Holter monitor or event monitoring. Holter monitoring is if you were to work for a cardiologist, you would place this in the office often. So I'll give you an example. So my daughter, who I think I've given y'all some examples of her, she was born with a heart defect, and a couple of years ago, she kept feeling a fluttering, more so than normal. And so they decided they would do a Holter monitor. So what that is you go into the office, and it's fewer leads, so it's just a few leads on the chest, and then there's a small box that the patient will kind of clip on their belt, and they wear that for 24 hours. And every time they feel faint or they feel whatever flutter or unusual feeling they've been feeling, they press a button, and it marks that on the printout. They wear it for 24 hours usually. Then they take it back. The doctor prints out, hey, what all happened in this 24-hour period, and they can actually see. So basically, it's like an EKG to go. Is one way to think of it. It's like an EKG to go that you take home for 24 hours. You can't shower with it. You leave it on. You do your normal activity, but it's monitoring you for 24 hours. And you can also, again, you can click a button anytime you're having an unusual symptom of any kind, and it will alert the doctor that, hey, this is where I felt funny. Like in my daughter's case, it was right on, and she was having some unusual beats, and they were harmless. But that's a good example of a Holter monitor. Okay, so I will come down and bring my skeleton and talk to you a little bit about lead placement. I want you to look over this material in the book and then take the quiz. Just like yesterday, you don't have to, no need to upload a grade. I'll just go in and look at all the quiz grades. But you need to get the quiz done. Okay, and I'll be down, so if you have questions about yesterday's video or today, that'll be the time to hit me up. Okay, guys? All right.